the presentation on how technology revolutionized the way we practice neonatology. So I thought I will just go over two routine cases, a term baby and a preterm baby who come to our ICU, and then how our management changed changed with things that happened along with technology. 1 second. All right. So outlining it, I'll be talking about advances in terms of taking care of a term baby, taking care of a preterm baby, things that changed in community with community neonatology, and of course the stuff that are that change the practice in an ICU as well. We all know technology is essentially our imagination. What we want, we try to create, and thereby we make our lives easier. So I'll just what I believe is, if we don't look at our history, we won't really progress much further. So our history teaches us quite a bit. So in the early 50s, is the gynecologists and obstetricians who used to take care of preterm babies. So till the time, it was always believed that preterm babies had no scope. Okay, yeah. So in the early 50s, the preterm babies were taken care of by incubators which are made of wooden furnaces, and then they had glass covering, and they used to pour hot water, which used to go and make sure the inner surface is warm. And an OG tube or an NG tube was placed, and they were fed with mother's breast milk. And they demonstrated that this is the kind of care that is needed for these babies to survive. And 5 years before that, all these babies had no chance of survival. A huge step that has happened in the early 50s, and then subsequently, when nobody believed it, they had to have this kind of exhibition programs like infant incubators or infant hatcheries, and they used to show as a public show to all the people, so they believe that this is possible, and thereby future advancements are possible. From that humble beginnings, here we are in the future talking about ex utero complete formation of a newborn baby called complete human embryos outside. So the day won't be very far when we see that babies are made from scratch, from an egg and a sperm, and to have a complete baby outside completely. Till that day, we will discuss about what are the things that we are seeing in NICU these days. Okay, so I'll be talking about one hypothetical case. Mrs. Purnima, let's say, 24-year-old primary lady, came at 39 weeks, spontaneous onset of labor, no surprises there, and then she had no known antenatal risk factors. So when this lady is in labor in my labor room, and I get a call saying that such a lady is waiting for delivery, so the things that will go through my mind are what is happening with the progression of labor. So if there is a prolonged labor, would the baby land up in perinatal asphyxia? And who is taking care of this fetus inside the mother's tummy? Like, what are they doing? Are they just auscultating? If auscultation is the standard of care, is it enough? Is it safe? Is it reliable? When the problem is this, then the solution that was given by technology is nothing but electronic fetal monitoring, or CTG, which we see routinely in our labor rooms today. So these are the machines which make a lot of noise in the labor room. They will tell how the fetus is responding to mother's uterine contractions. So if there are, so it sounds fantastic. If the baby is not withstanding the pressure that is put in the uterus by the mother, then the baby is in trouble. Then we try to deliver the baby earlier. So technology sounds very good. Yeah, the fetus is not doing good. We need to pull the baby out so that the baby is more viable. Now, what happened to the studies? What did they say? Like, if we use routine electronic monitoring, did we manage to prevent perinatal asphyxia? Did we completely eliminate perinatal asphyxia and thereby cerebral palsy? So did the technology get a thumbs up from the clinical care, or did we say that no, it's not going to work? So we have a Cochrane which has come out in 2019, which reviewed roughly about 37,000 women who were monitored with CTG. They found that using an electronic monitoring program versus routine care, that is auscultation, there is absolutely no difference in perinatal mortality. There is no difference in cerebral palsy rates. However, because you have a machine which is telling you that the baby may be in trouble, you're obviously doing more cesarean deliveries and more instrumental deliveries. So probably as of today, the way we are using the CTG machine, the technology is good, but we really don't know where to place it so that we can use it for our benefit. However, there is a small rider there in the whole in this Cochrane which said that the neonatal seizures in these babies who are monitored by CTG are not lesser than those babies who are not monitored. So there is some bit of hypoxia which is probably picked up by the CTG, thereby we are pulling these babies out earlier. So the problem is very high false positivity rates of CTG, thereby we are probably pulling out babies. So what are the other things that we can do in the labor room? Obviously in the late 90s and the early 2000s, they said, when I was an intern, we used to do a lot of fetal scalp blood pH. We said, let's look at the pH, and if the pH is acidotic, let's think that the baby is probably compromised and thereby deliver the baby out. Now, when this is being done, the obvious question is, scalp is completely peripheral, and peripheral hypoxia wouldn't probably mean much. Peripheral acidosis probably wouldn't mean much as long as the heart and brain are all right. So in the late 2010s and then early 2015s, there came a new technology called STAN. STAN means ST segment analysis. That means along with the CTG, that is the cardiotocogram, the continuous electronic monitoring, they managed to place a small electrode on the fetal scalp. This assesses the fetal ECG and gives a ratio between the T wave versus the QRS wave of the fetus. So if there is a baby who is compromised and baby is hypoxic, if the effect of hypoxia is on the baby severe enough to cause changes in the heart, probably those are the babies to be delivered earlier. So when they looked at this STAN analysis in the initial pilot trials, they found that it managed to decrease about 40% of cesareans. They said even though the CTG is abnormal, the STAN is normal. Together with STAN, probably we can wait a little longer than doing a cesarean section. And a good number of these ladies went into progressed in labor and delivered normally. However, when we pulled a lot of data, put together 6 trials looking at what does STAN do, is it good enough yet? We found that absolutely it didn't make any difference yet. So again, the technology is extremely sound, probably very logical, but we really don't know the right point where we need to apply it. So there is a new trial that is already registered under Cochrane called START. That is the Australian randomized trial planned for next 3 years, and probably we'll know more about the uses of this particular technology called STAN in the labor room. So if this particular lady delivered this baby who required resuscitation. So what are things that we need to keep in resuscitation? The things that we need to keep in our mind during resuscitation are, first thing is obviously we need to have a careful and a reliable way of looking at neonatal heart rate during resuscitation. Because we all know heart rate sinking is a poor sign of resuscitation. Heart rate raising above 60, above 100 and staying higher obviously is good. We started using ECG leads from 2015 NRP program. The new in thing is there's a trial of using a little Doppler, which can be affixed onto the fetal chest, and thereby we know how much is the reliable heart rate directly. There are other things that we also looked at how a resuscitation program can actually make better, but then we'll look into that maybe 5 years down the line. Second important thing about resuscitation and what is the new advancement. The new in thing is probably it is better for the baby to breathe before we stop the placental circulation. That means clamping the cord or separating the baby from the mother's placental circulation before the baby establishes good breathing may not be a good idea. If that is the case, then how can we resuscitate these babies next to the mother? So there are a lot of machines which are in the market, which are already in the market. An Indian company, Chennai-based company, is also working on a very low-cost machine of similar sort, where you have everything. You have a warmer where it gives warmth from below. You have a pulse ox. This can be placed right next to the delivery suit. If it is a cesarean, you have a place you can actually draw this trolley close to the mother's leg end, and you can take the baby. While the cord is still intact, we can begin our resuscitation process. This particular machine has everything. It has provision to give CPAP, it has provision to give pulse ox, and it has provision to give warmth. So the warmer, which used to be a little far away from the delivery suit, is brought right next to the mother so that we can keep the placental circulation intact. Now, if the problem is, say, for example, this particular baby who is required prolonged resuscitation, this baby is prone for brain injury. We are all very worried about it. That's what we're talking about, perinatal asphyxia. These perinatal asphyxia babies, how can we conserve the damage? Basically, if there's already damage has occurred, how can we minimize the problem? Then the new next thing that came in was neonatal cooling. We have been hearing about it for the last 15 years, and in India right now it is being done in every nook and corner of the country. We need to make it more popular among obstetricians. We need to make it more popular among every person attending delivery, so that any child with perinatal asphyxia deserves to be cooled if they meet the criteria. So what is the theory behind it? The theory is, if we are able to give it within the first 6 hours of life, and then maintain the management well, and also the rest of the supports such as cardiopulmonary and all the other supports, sugars and seizure control and all that, probably we can limit the damage. So the Cochrane analysis showed that for every 8 babies you cool, you are preventing 1 baby with either death or severe neurodisability. Is the number large? Absolutely not. Because if we have to really control the damage that is done because of perinatal asphyxia, this is probably one of the very easily practicable, and at the same time does a lot of good to the babies who deserve it. There are a lot of things that we are trying to add. We are too greedy. We are not happy with the number you treat of 8. We want to be 3, 4, 2, or maybe every baby who has asphyxia deserves to get better. So we can add multiple other things such as Maxel, we can add Xenon, we can add topiramate. A lot of these trials are going on right now in this country, and once the data is available, we can actually make it more clinical practice. Now, then the interesting question comes as to why is schooling, why when it is so popular in the West in 1995 and 2000, why didn't it happen in India till recently? So obviously in India, when we are talking about Indian scenario, we are talking about cost. A cooling equipment, when I was in my student days, used to cost around 35 lakhs. That is prohibitively expensive for Indian scenario. Responding to that, there is a little known company in Uttar Pradesh who worked with phase change materials and gave us a very simple, easy to practice, easy to use, less than a lakh equipment, which we can use routinely by little training of our nurses. One of the papers by one of my close friends published showing that we can use simple ice gel packs to bring down temperature, and thereby we can do the cooling. Or we can use the particular phase change material which I was talking about called Miracadil, which is very popular now. No matter what you use, the temperature control seems to be fantastic. So we don't really need a very high-end equipment to do it. With a little effort and with a little bit of training of nurses, with very low cost technology, we can actually make cooling a possibility in every part of the country. Now, how do we monitor or predict this kind of behavior? How do they do what happens to these babies? The first question that any parent would ask us is, will the baby be all right now? Will the baby be all right in the future? The first thing is, important thing is, we need to identify and control seizures. So identifying seizures in a newborn is extremely hard, irrespective of our clinical judgment, irrespective of our experience and all that. So there are, addressing this concern, the technology comes up with another simply practicable technology called amplitude integrated EEG. The normal EEG, the conventional EEG is very big. Bringing it right to next to the bedside gets a little hard. We just have a 4-lead EEG, simple machine, which we can bring right next to the baby's bed. We can attach it to the baby. We can monitor baby's brain activity over the next multiple days, when however long we want to see. So the first 6 hours of the EEG in the baby's life will tell us whether the baby already suffered any damage or not. So we can make our choice of cooling very easy. And the time that is taken to make, say for example, a baby has abnormal EEG, and then that becomes normal very quickly by the next 24 hours, the next 12 hours with our supportive management. That's a very, very positive sign. It's a very good positive sign, probably the best, earliest predictor to show that this baby may not really suffer a long-term problem. So you have a beautiful machine here which tells you who is the baby at risk, how do I identify seizures, and also tells you whether you need to treat them or not, and finally it also tells you whether this baby is going to have long-term problem or not. Simple piece of equipment doing fantastic good bedside. Here, this is one of my favorite pictures when it comes to amplitude integrated EEGs, which shows that those babies whose EEG normalized early remained normal in the long run at 18 months or at 36 months. Those babies whose EEG remained abnormal either died, or the babies also remained abnormal. The longer the EEG remaining abnormal, the babies also remained abnormal subsequently. So this is an equipment which is going to tell you and help you with your counseling, which is very, very important in neonatology. Now, so all that is brilliant. So the brain here suffered a little bit of injury, and the brain is we are doing all that we can to treat it. The next thing is, can we even further refine and see, is the brain getting enough oxygen or not? So we can actually look at something called tissue oxygenation, key for the which is obviously the key for the outcomes. So here is a piece of equipment which throws a little bit of source that gives you a particular wavelength, and then there are detectors which are going to pick up the data. This will tell you the oxyhemoglobin standards, the deoxyhemoglobin standards, and thereby will tell you whether the regional oxygenation is good or not. So this can be done looking at the head. For a term baby, obviously we're talking about asphyxia. In a preterm baby who suffered IVH, in a preterm baby who's not doing well, in a baby with seizures. So implication, the areas where you can apply this tissue oxygenation studies are really limitless. Even for NEC, you can look at intestine, whether the intestines are being actually perfused well or not. So the areas where we can apply this technology is limitless. This technology is available in India now. Currently, there is a center in Bangalore I am aware of which has this readily available. It is going to be available soon for most of us to use it in the next 5 years. It looks as simple as this, and you're going to have data which you can use so that you can actually monitor the management for the better. Now, so existing technologies such as MRI obviously are important tools that we use to see how things improve. Now, MRI itself has seen really vast changes in the last 10 years. So you have I'm just going to show you a picture which shows you about this is called looking at the lactate peaks and looking at the choline peaks. You can actually predict whether the brain has suffered any major problem in this kind of MRIs. These are the earliest pieces of MRI, earliest piece of evidence you get on an MRI. On the right side, I'm going to show you multiple images of MRI. The first one is a baby who moved quite a bit. This can be refined to make it look like as clear as the next one. So you don't need the baby to go through the whole MRI again. Even if the baby moved, you have algorithms which can refine the data. The third one is called tactography. In the sense, it can tell you if the baby suffered a stroke or if the baby suffered an IVH, whether any part of the tract or anything has suffered any damage. The fourth one, the colorful image, shows you about the density of various types of tissues, the volume of them, telling you whether the baby has had any major problem or not. So, and finally, of course, the vascular markings of the arteriography and the venographies also give you enough clues in MRI. So MRI as a technology has seen vast advances in the last 10 years. And that can be applied into neonatal care. So leaving the aspects aside, what are the other smaller things that we use day in and day out? Okay, so all of us are very happy with this particular piece of equipment. The parents are very happy where you really don't have to prick the child multiple times to look for jaundice levels. Here's a simple piece of equipment. You can put on the baby's skin. It will give you a number. The number is very reliable, and it is going to give you graphs. If it is more than 75th centile, please do a repeated test. If it's more than 95th centile, then I think you should closely admit the child and repeat the test, so on and so forth. This is a simple, easy to measure bilirubin assessment bedside. The commonest reason why a baby is brought after discharge of a newborn, after discharge of the newborn admission is jaundice. And here is a piece of equipment which keeps a smile on the doctor's face, or the nurse's face, and the parent's face. Now, the simple new thing that we're looking at is like what now, once the phototherapy is done, obviously the skin is bleached. It's difficult to see the jaundice with cutaneous bilirubinometry. So now we are looking at various ways of changing this technology to see whether we can actually apply the same thing even in these babies. So even a baby who has underwent phototherapy, there are ways we can use this machine, and thereby we can actually reliably look at jaundice levels. Thereby we can avoid multiple blood samplings. How cool is this technology? Now, now this is leaving the term baby aside. Now I'm talking about the preterm baby. So we all know that providing PEEP in the labor room is extremely important. One piece of equipment which we are very happy with is TP resuscitated, or the common colloquial is baby puff, neo puff, and all those. Brilliant. Now, what fascinated me recently is I've seen a machine where you have ambu bag with a PEEP well. You don't really need to buy the 40,000 equipment. Actually, this is only about 1,800 rupees. So if we have a very low cost area, then this is very easy to invest into, and you can get 5 of these ambu bags, and actually there are studies which are showing that it provides a reasonable amount of sale and a decent amount of PEEP, so that you probably can get away or with a lower bit of cost. Coming to ventilation, when we are ventilating a preterm baby, that's an important area that we need to worry about is oxygen exposure, the ventilated trauma, and all that. So this is a particular type of this is a technology where we can use a software to do a trial called Bayesian network meta-analysis. That means where we can compare multiple prongs of management. Like in this particular trial, they compared whether we can do intubate to the baby, whether we can give surfactant by least invasive surfactant therapy, we can give just CPAP, we can give mechanical ventilation, we can use laryngeal mask gas airway. It's impossible to do a trial comparing each one against each other or all these prongs. But even if you already have evidence available, you can just feed in the data and you get to know which is the best choice and the worst choice. In this particular thing, if you are practicing least invasive mode of giving surfactant administration to a baby, to a preterm baby, that's probably the best way to go about taking care of a preterm baby. The second one being NIPP, third one is insure, and so on and so forth. We will discuss it on some other date on BPD. The other newer technology about ventilation is something called NAVA. So the most important part of ventilation is trying to synchronize the baby's breathing with ventilation. Synchrony of the baby with ventilation can be best done with various things, like with a good flow sensor where the baby is breathing, the machine detects the baby is breathing, the machine gives a breath. The best way to assess synchrony is something new technology called NAVA, where you put in a probe inside the baby's esophagus that will pick up the nervous impulse of diaphragmatic contractions. The moment the machine gets to know the diaphragm is about to contract, it will give the breath because it knows that is the first step of taking a breath. So here you have a piece of technology which maximizes synchrony, minimizes any discrepancy between baby and the machine, and thereby gives you the smoothest form of ventilation. The next level of ventilation is where you have so the traditional way of ventilating is you have a baby on ventilator, you ask for a blood gas, you see the blood gas, doctor sees the blood gas, makes the changes of the ventilator, repeats the blood gas after some time, and then sees what happens. If the FiO2 of the baby is high, we see the pulse ox, the oxygen is high, we try to come down slowly. Now that era is probably slowly going away with these new ventilators who are integrating the oxygen, the blood gas CO2, the baby's breathing efforts, everything is taken into account, where the clinician is probably taken out of the equation in weaning the ventilator parameters. There are already trials which are showing that it is possible, and probably that is the next stage of looking at ventilating a small baby, particularly when we are not there next to the baby all the time. A talk on technology becomes useless in neonatology if I don't talk about focus. Focus is point of care ultrasonography in neonatology. It is so beautiful. The bedside ultrasound can look at heart, head, abdomen, chest, lines, plastics, you name it, we can use it for anything. People who have started to use an ultrasound will refuse to work in a unit or will find it extremely difficult to work in a unit where they don't have an ultrasound. That is the stethoscope of the future in neonatology. I don't remember regularly using a stethoscope in the last few months when I'm using the ultrasound regularly on babies' hearts, because whether a murmur is there or not, it will tell you whether the way the murmur is originating from and all these things. It also will help you fine-tune management in terms of fluid boluses, in terms of inotropes, in terms of weaning of inotropes, in terms of how to assess a baby who's sick. This will help you identify what is the lung pathology, whether it is pneumothorax, whether it is RDS, whether it is pneumonia, so on and so forth. It even helps you understanding the position of your lines, your tubes, and all that. In the previous unit we was working, we had a practice of regularly looking at the ultrasound position of UVC and USC when we're putting the lines itself, so that we don't have to manipulate them multiple times. And we realized the lesser that we manipulate, the lesser the infections are. If your ICU is having a simple machine which tells you and brings down infection rates, that is a brilliant equipment and piece of technology for us to have. It definitely focus is the area to focus for the future, because every person trained in pediatrics and neonatology probably needs to focus on looking at the multiparameter monitor. There is a small piece of data called perfusion index. So this tells you about the strength of the pulse that is generated. That's where the pulse is generated from. So I did a small study when I was a fellow, looking at the perfusion index of the preductal site, that is before the PDA, and postductal site after the PDA, between the right hand and right leg. So we said if the PDA is very strongly active, it will steal blood from the aorta. Thereby, your pulse, which is strong in the right upper limb, will probably become a little weak in the right lower limb. Let's look at the difference and whether can we diagnose a PDA just on pulse oximetry. When we did this study, we found that there are cutoffs which we can arrive at, and we can diagnose a hemodynamically significant PDA very early next to the patient with simple pulse oximetry. Now, talking about pulse oximeter, there is a particular piece of technology called hero analysis. So now it is believed that if we are at a healthy heart, if a newborn baby is healthy, then the heart rate will actually swing between normal levels. So the heart rate will become low and high depending on whether the baby is active or sleeping, or whether the baby is based on the status of the baby. But once the baby gets to become very sick, then this variability will decrease. The heart rate will become strict and a single number. And when that becomes, it can actually help you pick up problems beforehand. So when they looked at hero analysis in terms of sick conditions in neonatology, such as NEC and sepsis, the hero analysis can predict these problems roughly 24 to 36 hours before they actually show clinical signs. So if a baby were to become sick day after tomorrow, this machine will tell you, watch out for this baby. This baby is not looking good today. How brilliant is this equipment? This equipment is going to be available in Indian market in the next 2 or 3 years, and probably a good place to look into. So there are a lot of trials, a lot of studies, which I'll share my mail ID, and eventually if we can get in touch, then I will tell you. I will share all the studies that will tell you about this equipment. Now, looking at technology that makes the diagnosis very easy. So we are looking into an era where we need diagnosis very quickly. Send a sample today. I want to know by the evening if I have an infection. I want to know by the night if a baby is going to suffer in the future or not. So a lot of biomarkers are there available where we can look into. And the biomarker technology is becoming even bedside. We will have card tests where you put a sample, a drop of baby's blood and a buffer probably, and we'll have reports ready very soon. The Exciton is a Bangalore-based company which started the PCR technology for infections. So the PCR technology predates any blood culture positivity by roughly about 42 hours. That means it's going to give you a report by 6 hours, where our technical traditional blood culture will take about 48 hours. So you're already ahead of the game. And this PCR technology will also tell you what drug it is going to be sensitive to. So you're going to know about blood culture positivity. You will also know about the sensitivity pattern. Now, there is an algorithm which interests me to discuss in a preterm baby. In a preterm baby, now in the US, where there are areas where the pediatric ophthalmologist is not routinely available, so they came up with an algorithm which can predict a baby who can end up in ROP or not. So there's an algorithm which will tell you about the baby's birth weight, baby's gestation, and the weight gain in the first 6 weeks, and it's going to tell you whether the baby is at high risk or low risk for ROP. Thereby, if it is easily available, there's no problem. But if you're not finding a pediatric ophthalmologist, you can use it to push a patient saying that you may be at high risk for ROP, please go and get tested. Talking about community neonatology, so there is this beautiful wristwatch for newborn babies, which has come out from, again, a Bangalore-based company, which identifies hypothermia and it alarms. So it's going to tell the mother, check out on your baby's temperature is dropping below the limit. And thereby the mother can pick up the baby, wrap the baby, and do, because we all know hypothermia is very dangerous for babies. This is called Bempu watch, very popular and available on Amazon today. This is the new equipment that the same company brought out called apnea boot. So this particular piece of equipment has a pulse ox and a stimulator that is attached to the leg of the baby. So it's like a boot that the baby's leg is placed into. If the baby has apnea, this boot will vibrate very strong so that the baby wakes up. So the baby has apnea, it will wake the baby up quickly, and it's very useful for the ICU where monitoring can be little doubtful. This is St. John's rattle. This is used as a single community-based equipment to do hearing screening. So this checks the basic hearing of a baby in the community. It's almost literally less than 10 rupees, where we can use it for routine screening in the community. Soham is another equipment that has come into the Indian market, which does the automated BERA used for wide-scale screening. There is this remote biosensor equipment that is a chip that can be placed on the baby's tummy. This is going to identify hypothermia, but the beauty of this technology is this is hooked up to the satellite. The satellite will send a signal and send a message and a phone call to the mother saying that your baby is getting hypothermic. Please check the baby. Please check on the badge which is nicely attached or not. It's a beautiful device that has come from Indian Institute of Science from Bangalore. So it may be available for commercial consumption probably in the near future, but as of today, research, but beautiful technology will come soon. This is internet-guided ROP screening. In those places in the periphery, in the extreme ends of our practice, in our remote villages, can we send somebody to do ROP screening? This is something called Trinetra, or a machine which is very cost-effective. All it takes is one guy who has done his 10th standard. He is enough for being trained. So he'll go to any corner with a vehicle, take a picture with this particular equipment, and the picture goes onto the internet, goes to the central database, and from Narayan Netralaya currently in Bangalore, they will give a report whether the baby has ROP, no ROP, and the turnaround time is less than 2 days. So within 2 days, you get to know whether the baby is sick. So the moment you have the data, you can alert the family and they can actually come to higher center for laser or any subsequent management. This has been validated and published multiple. Karnataka initiative for ROP as a program called Kid Rope, and it is very successful in Karnataka. I'm sure a lot of other states are looking at implementing the same. Data keeping in NICU, the last part of my talk. Unless we look at our own data, unless we compare our data with other ICUs, we don't know what is happening with our ICU. This is a broad data looking at various countries, comparing as to why one country is doing better than other country, what practices are different from that country to our country, thereby we know how we can change. So there is a small study that we looked into when I was a DM student. So we looked at infection rates in the ICU. We figured out what is going wrong in the unit. We made small changes to the practices, and we realized we can bring down infection rates dramatically. There was an 89% reduction in CLABSI rates, that is central associated bloodstream infection rates in the unit over a period of 6 months. In 6 months, just by looking at our own data with the help of a little bit of technology and training, we could bring down the infection rates by 90% in the unit. The overall mortality of the unit has drastically dropped. So looking at our own data will always help us this thing. And if we have our EMR, electronic medical record keeping, if we have our database, if we compare our data with our colleagues or friends across states and all that, we would probably learn a lot how to take care of our babies. Last part, having a baby in the ICU worries the families. So now we have a simple webcam attached to baby's warmers and baby's incubators, and that can actually have an access to the parents sitting at home. This will alleviate any kind of doubt or any kind of worry that the mother has. So if the baby were to be in the ICU for 60, 70, 80, 90 days, if the mother has to sit at home at peace, she probably can actually access how the baby looks, what the baby is doing at that point of time from home and from her mobile. So this takes away pressure from the family. This builds the confidence in the system. Parents will believe what we are doing more often because nowadays the trust in medical fraternity is decreasing day by day. Summing up, every medical challenge when brainstormed with available resources, we can have technology will probably address the area very well. Solution should be put to test, and we should actually arrive at a exact application of what technology we have in hand. Bedside rapid techniques, technologies, and data sciences is the future which we need to look into because that is going to transform the way we practice neonatology. Thank you. I'll be happy to take any questions or any comments. And this is my mail ID. I can always.
Thank you, sir, for the very informative presentation.
Thank you,
Am I audible?
Yes, sir. Yes, sir. Thank you, sir.
Thank you, sir, for your very informative presentation. Especially the technological advancement in the chronological order, and also so many aspects like neuroanalysis, exciton, such recent advances also you have mentioned. Its topic is open for discussion. Hello, over to Sumita. One question from the net, that is to Dr. Bini. Is ABG analysis is mandatory for the initial assessment of a cyanotic newborn? Can you stop sharing, sir?
Yes, sir. Yes, sir. Yes, sir. How do I stop? Okay.
I wouldn't say ABG is mandatory in the initial assessment, as I have already discussed in my slides. History and physical examination, a targeted physical examination is always part of your initial assessment. And if you're getting a baby with a fixed hypoxemia, not much improvement with oxygen, your ABG will help to corroborate your diagnosis. I won't say it is a mandatory thing in the initial assessment. Even the traditional hyperoxia test has been obsolete now, both because of harmful effects of oxygen as well as the technical challenges in getting 2 ABGs done. So it wouldn't be mandatory in the initial assessment.
Sir, one question to you. Normal NIRS value of brain to monitor.
Sir, the NIRS values depend on the day of life, time of life. We have graphs available, sir, which we need to look into and then compare and see the baby's gestation and all that, sir. So we, like in any neonatal parameter, most of them are time and gestation based, sir. We have a lot of data available around that, sir.
There are no other questions in the net. In the chat, there are the 2 questions only. Over to Dr. Samita.
Thank you, sir. Am I audible?